Dear all, I would like to welcome you to today's episode of Brain Pet Talks. These talks are supported by Postrigo, which is a pioneer in nuclear medicine imaging technologies. Today, the focus will be on tau PET. We are very happy to have Dr. Rik Ossenkoppele with us. Rik Ossenkoppele is an associate professor in translational neuroscience and principal investigator of the Alzheimercenter Amsterdam of the Amsterdam UMC and at Lund University in Sweden. He works on the intersection between neuroimaging, biomarkers, and cognition in Alzheimer's disease. His main motivation is to contribute to improving the diagnostic prognostic workup, that's a short-term goal, and curing Alzheimer's disease as a long-term goal. Dr. Ossenkoppele received several prestigious prizes like the European Grand Prix for Research on the Foundation of Alzheimer's Disease in 2019, the Young Investigator Research Award from Alzheimer Netherlands in 2020, and the Queen Sylvia Research Prize in 2021. In addition, he received several research grants like an ERC starting grant and various dementia research grants. He is an editorial board member for the Alzheimer's Research and Therapy Journal and for the European Journal of Nuclear Medicine and Molecular Imaging. He's program committee member for several AD and FTD imaging conferences and chair for the atypical AD professional interest areas of the Alzheimer Association. Dear Dr. Ossenkoppele, we are looking very much forward to your presentation. The floor is all yours.
Yeah, thanks so much for the kind introduction, for the opportunity to present about tau PET in Alzheimer's today. And what I would like to cover, here are my disclosures, by the way. What I would like to cover, I would like to start with a brief history of tau and tau PET in general. Then we'll discuss the role of tau PET in the clinic. Then we'll move on to the role of tau PET in trials. Next on, we'll discuss tau PET versus the elephant in the room and end with the take-home message. But let's start with a brief history of tau PET. So I think this whole story started early in the 20th century when Alois Alzheimer and others discovered a structure that looked like this, what you can see here, the so-called neurofibrillary tangles. But it took roughly 80 years before it was discovered that these tangles actually consisted of a protein called tau. So in normal physiological conditions, tau stabilizes the microtubules, but in Alzheimer's disease, tau becomes hyperphosphorylated. It gets detached from the microtubule structures and then aggregates into paired helical filaments that form intracellular neurofibrillary tangles. And this is very important because pathological tau has been associated with neuronal dysfunction, with cell death, and cognitive loss. But it made it a very promising target for drug development, but also for the development of biomarkers that can closely track progression of the disease. And roughly since a decade, we are now able to actually measure regional tau pathology in the living human brain using tau PET. So in my talk, I will roughly summarize what we have learned during the past decade. So the initial tau PET studies, I think, were quite exciting because what we very consistently saw across study is if you, in this example, go from the left to the right, from A to G, we can see an increase in tau PET signal. So the hot color, the yellow, the red, the pink colors indicate that there's greater tau pathology in the brain. And this increase in tau pathology was associated with a decline in the MMSE, which is a very global screening test for cognition. So we can see this go hand in hand, an increase in tau pathological load and a decline in cognitive function, very consistent across studies. But there was something else about tau we discovered here, and this is the first patient we scanned when I was a postdoctoral researcher at the University of California in San Francisco. And it was a very specific individual. The person was diagnosed with posterior cortical atrophy, and this is the so-called visual presentation of Alzheimer's disease. So they don't have predominantly memory impairments, but the problems are really more into the processing of visual information. You can see an example here, and this is an attempt to copy the figure above, and you can see that comes with a lot of problems. So we conducted 4 imaging modalities in this person. So here you can see the structural MRI scan. And the first PET modality we did was with PIB, which is a tracer that binds to amyloid beta plaques. And what you can see here is that the distribution of the tracer is very widely distributed across the neocortex. So it involves the posterior parts of the brain, but also the anterior brain regions. A rather aspecific and very widespread pattern. Then next we did an FDG PET scan, which measures hypometabolism in the brain. And here, if you look at the red arrows, you can see that the region of hypometabolism, so the areas pointed here with the red arrows are areas that show a lack of sufficient glucose metabolism, that they are quite specific to the phenotype of the patients because they are mainly in the posterior part of the brain, which we know are very important for processing of visual information. So then the big question was, how will the tau PET scan look like? Is it more generic, like the amyloid beta PET scan, or is it more specific, like the FDG PET scan? And we found that the latter was really the case. So essentially the tau PET scan, done in this case with the tracer fluortaucipir, was almost a mirror image of the FDG PET scan. So if you would overlay the tau PET scan on top of the FDG PET scan, you can see that regions with a very high tau load are also the regions that are showing glucose hypometabolism. So again, very, very specific. And this was confirmed in many, many other studies. And it showed that not only the total tau burden matters, but it's also really the regional location of tau pathology that dictates the clinical phenotype of individuals with Alzheimer's disease. So we're in a very lucky and fortunate position nowadays that we have multiple very good tau PET tracers. I already showed you fluortaucipir, which was probably the first one that was being developed. I'm showing here a couple of more. There are even more that I'm not even showing, but these are probably the 4 most widely used tau PET tracers nowadays. What they have in common is that they very clearly distinguish between people that don't have any cognitive symptoms, so they would be considered normal, versus individuals that have Alzheimer's disease either at the MCI stage or at the dementia stage. So you can see clear differences. And also the pattern is very similar. So what we typically see is an uptake that involves the lateral temporal parietal cortex. You can see involvement of the medial parietal cortex, so the posterior cingulate and the precuneus. And also in the medial temporal lobe, there is sufficient uptake. So we see that really consistently across the PET tracers. So that's sort of a background on tau PET. And then, of course, it's interesting to see how we can apply this in the clinic to potentially make the lives of the patients and the caregivers better. So this was a very initial study we did in 2018. It was a multi-center study across Sweden, the United States, and South Korea. And in this study, we looked at the capability of tau PET to differentiate between Alzheimer's disease and other types of dementia. So in the first step, we looked at 3 different groups. So we had a group of healthy controls. We had a group of amyloid beta positive people with mild cognitive impairment. This might be considered a transition stage between cognitively normal and Alzheimer's disease dementia. And then this is the Alzheimer's disease dementia group. And everyone in this group was also amyloid beta positive. And what we can clearly see here is that when we go from controls to AD dementia, there is an increase in overall tau PET load, really gradually changing from controls to mild cognitive impairment to Alzheimer's disease dementia. But to me, what's more striking is the difference we see between Alzheimer's disease dementia and in this case, all the non-AD neurodegenerative disorders combined. So this group is really a mix of frontotemporal dementia, vascular dementia, dementia with Lewy bodies, etc. You can clearly see visually here this difference between AD dementia and the non-AD types of dementia. Of course, we also quantified the tau PET signal, and we did this in a region that's very specific for Alzheimer's disease. So we quantified the uptake of the tau PET tracer in the temporal meta-ROI. So this includes several highly relevant regions for Alzheimer's disease. We calculated the cutoff. You can see it in the dotted line here. And if you're above this cutoff, you're considered to be tau PET positive. If you're below the line, you're tau PET negative. And what we see is that the vast majority of the individuals with Alzheimer's disease dementia are indeed above the threshold. So they are tau PET positive. The same is true, although to a lesser extent for individuals with prodromal Alzheimer's disease or amyloid beta positive people with mild cognitive impairment. And then across most of the other groups, the vast majority of them are tau PET negative. And this consists either controls, other types of dementia like frontotemporal dementia, individuals with language disturbances, Lewy body disease, movement disorders. The vast majority of them is indeed tau PET negative. And if you then calculate the diagnostic performance, we can see that both the sensitivity and the specificity here is around 90%, which I think is quite good for a diagnostic marker. And then, of course, the big question is, how does tau PET perform in primary tauopathies? And I think this is a really important question, because for Alzheimer's disease, we already have quite a wide availability of biomarkers that are pretty good in detecting Alzheimer's disease early on, or differentiating between other types of dementia. But this is not really the case for most of the other primary tauopathies. And when we say PET, you might expect that it indeed does bind to other tauopathies as well. And we now know that this is only the case to a certain degree. So this is a study done in progressive supranuclear palsy, which in most cases leads to movement disorders. And at the individual level, you can see some really nice examples of tau PET positive images, right? So here, including a very PSP-like signature of tau PET uptake. But there are also individuals that are completely tau PET negative, with only some what we think is off-target binding. And then if you look at the group level in two regions that are highly specific for PSP, so for example, the globus pallidus and the putamen, we can see that the patient group, the PSP patient groups in red, are indeed at a group level showing higher tau PET uptake compared to 3 different control groups. And this resulted in a sensitivity of 85% and a specificity of 77%. And this raises the question whether this is sufficient for use at the individual level in the clinic. I think this is still an ongoing debate and a topic of research. Then the behavioral variant of frontotemporal dementia, where we know that a substantial portion of them is also caused by a primary tauopathy. And if we simply compare a group with Alzheimer's disease dementia against a group with sporadic frontotemporal dementia, we can see that there's barely no uptake of the tracer in frontotemporal dementia. And also when we look at a cortical basal syndrome, which we know in roughly 75% of cases is caused by a tauopathy, and in the remaining 25% is caused by Alzheimer's disease etiology, we can see that if an individual is amyloid beta negative, then the tau PET scan is almost exclusively also negative. There are some white matter binding we see that's consistent with neuropathological literature, but it's probably too subtle to be really useful, for diagnosis at the individual level. But then if we look at amyloid beta positive individuals, in which Alzheimer's disease is the most likely underlying etiology, we can also see that the tau PET scan is clearly positive. So this may help to differentiate between suspected cortical basal degeneration and cortical basal syndrome based on Alzheimer's disease. But in general, I think this slide really shows that the current tau PET tracers are very specific and have high affinity to the tau aggregates formed in Alzheimer's disease, and way less to the tau aggregates we see in the primary tauopathies. So this is still a major challenge for the field, to really develop tracers that are specific for detecting primary tauopathies, like PSP, like Pick's disease, and like cortical basal neurodegeneration. So with tau PET, one of the tau PET tracers is now approved for clinical use by the FDA. So we're now really entering also the clinic with tau PET. And therefore, it's of course really important to evaluate its potential effects. And a study design typically looks like something like this, where there is a diagnostic workup, there is a consensus diagnosis, then a tau PET scan is performed, the result is communicated with the physician, and then the diagnosis is re-evaluated. So to date, there have been 2 studies, at least 2 studies conducted like that. And in the first study, there was a diagnostic workup that it did not include an assessment of amyloid status. And in that case, the change in diagnosis was 28% after doing a tau PET scan, so really significant. And a slightly more recent study, and also more large-scale study, there was a diagnostic workup that actually did include an assessment of amyloid status already, but there was still a change in diagnosis in 8% of the cases after a tau PET scan was performed. So still an additional value. So these studies were relatively controlled. They were in research populations, and in some cases, tau PET scan may have been performed in individuals that would not be a very likely candidate in real-world clinical practice. So to address the clinical value of tau PET in that particular context, we are currently setting up a study that's called TAP-Tau, and that's a prospective longitudinal multicenter studies across 6 memory clinics in the Netherlands, where we will mimic the real-world clinical practice by including 300 individuals with MCI or mild dementia, who we think might benefit most from a tau PET scan. And we will include people based on a suspicion of mixed pathology, which is very common, as we know. So, for example, Alzheimer's disease plus Lewy body dementia, or Alzheimer's disease plus vascular dementia. Also, individuals with an atypical clinical presentation are very likely candidates because their clinical phenotype overlaps a lot with other types of dementia. And another scenario we think is very likely is that there may be conflicting biomarker results during the diagnostic workup. So, for example, there's conflicting information between the MR scan and, for example, information coming from a lumbar puncture and a subsequent CSF analysis. So we really hope to address this clinical value in the real world in the next couple of years. So to summarize the clinical part, tau PET has shown excellent diagnostic accuracy for distinguishing between Alzheimer's disease dementia versus other neurodegenerative disorders. In primary tauopathies, there might be a role for tau PET in the diagnosis of PSP, but most likely not for the diagnosis of behavior variant frontotemporal dementia or a suspected cortical-basal degeneration, at least not with the current tau PET tracers. And there seems to be added clinical value of tau PET, but I think this is also still a topic of active investigation. So let's now move on to the role of tau PET in clinical trials. Tau PET is increasingly used to select participants in clinical trials. One example is a recent donanemab phase 2 trial published in 2022, where they included people with symptomatic Alzheimer's disease, so either in the MCI stage or with mild dementia. And in addition, they required positivity on an amyloid PET scan. And I think nowadays this is sort of the default in the field. This is the minimal restriction when running a clinical trial. But there were two things that were special about this clinical trial. The first one is that they also required positivity on a tau PET scan. And I think the main reason for this is we know that amyloid positivity can also occur as an effect of aging, just a comorbid pathology, a secondary pathology that may not contribute a lot to the clinical phenotype. If you're additionally also tau PET positive, we know that the chances that someone has Alzheimer's disease as their primary contributing etiology is very high, and also the chances that they will clinically progress in the near future are higher. So I think this was done as an enrichment strategy. And in addition to that, they also incorporated a disease staging system that was also based on a tau PET. So they really focused on a group that had intermediate levels of tau. So individuals with no to very low levels of tau were excluded, and also individuals with too high levels of tau pathology were excluded. And I think the scenario here is that this group may not progress enough, and therefore may make it very difficult for clinical trials to detect a clinical benefit. And the high tau group may simply be too progressed in their disease, and it's very hard with at least an anti-amyloid beta therapy to expect a reasonable clinical benefit if you're in such a late stage of the disease already. So I think this is a very beautiful example of how tau PET has been used for participant selection. Tau PET is also more and more used as an outcome measure. For example, in these 3 anti-amyloid trials that have had a successful outcome in at least one of their trials. So from left to right, we see the aducanumab, the lecanemab, and the donanemab trial. And all of them showed a slowing of tau PET accumulation over time after amyloid beta plaques were effectively removed from the brain. One side note that's important to mention, for donanemab, this was true for the phase 2 study. In their pre-specified frontal cortex, this was not the case in the phase 3 trials. And interestingly enough, at the last CTAD conference a couple of months ago, it was actually shown that in essentially all the other regions of interest there was a slowing of tau accumulation, but not in the pre-specified frontal cortex. And then, of course, there should be an important role for tau PET also in anti-tau trials. So here's an overview of the current anti-tau therapy landscape. And I'm saying current, but this field is so rapidly evolving that this figure is actually already quite outdated. But at least there are 4 main sort of drug classes that have been tested so far. The most widely tested so far are the so-called immunotherapies, and we can also see that many of them have failed to reach phase 2 or beyond. There's also a quite novel approach where the goal is to lower the levels of intracellular tau proteins. And I would like to show you one example of that. So this is a recently published phase 1b study with the antisense oligonucleotide BIB080, 080, I think it's called. And what we can see here are tau PET images that belong to two participants in this phase 1 study. They're both patients, symptomatic, who are tau PET positive. So during the first 25 weeks of the studies, everyone was on a placebo. And what we can see here, if we just focus on the region that is indicated by the red arrow, we can see that there is a slight increase of the signal over time during this 25 weeks. And this is just presenting the natural evolution of tau pathology in Alzheimer's disease. So if you don't do anything, this is the amount of increase we can expect. But then during the next 75 weeks, people were treated with this ASO. And I think the results are quite remarkable because if we look at the same region of interest, we can see that there's a remarkable decline of tau PET signal in this region. And this was later also confirmed in region of interest analysis, and the effects were most pronounced in the temporal cortex, both medial and temporal. So we should be very cautious because this was a very small sample size. It was just a phase 1 study, but I do want to mention that these results are quite promising and especially highlight the role that tau PET can play in such studies. Already in these early trials show the potential of a particular drug to actually decrease the pathological load of tau pathology in the human brain. So far, I think it's still a big debate whether tau PET is the right target. I think it's extremely promising based on the preclinical and clinical studies we have seen so far. But it was still this question was raised in a recent editorial whether tau is the most valuable player or the tombstone. And the honest answer is that today we don't have a good answer to the question whether tau is the correct target to treat Alzheimer's disease. We simply don't know. What I do know is that tau PET will be essential to answer this question. And specifically, I think tau PET can play a role on at least 3 specific parts. One is to identify fast progressors. The other one is that I think we should move towards more individualized approaches. And then we should harmonize across the different tau PET tracers available just to make use of the infrastructure of tau PET centers. Let's first focus on the first one. So this study, I think, really nicely summarizes a big literature that exists on the relationship between baseline amyloid pathology versus longitudinal cognitive decline. And what we see here is on the x-axis, we see the scores on a test that is very sensitive for the earliest clinical changes in Alzheimer's disease. And on the y-axis, we see the follow-up duration in time. And if we compare the two groups, so those with normal amyloid in blue and those with elevated levels in orange, we can see that during the first couple of years, there's essentially no difference between those groups. This difference only starts to emerge after, let's say, roughly 4 to 5 years. And you can imagine if you are conducting a clinical trial and you have to wait so long to be able to detect a difference, it will be very costly. You would require a large number of participants in those trials to even be able to detect a meaningful clinical differences between the groups. So there are amyloid positive cognitively normal individuals are definitely at risk for future cognitive decline, but the progression rates are rather slow. So then we conducted a large multi-center study with the goal to identify fast progressors. And in these studies, we used amyloid and tau PET to identify 4 different groups. So the first group were those that were cognitively normal and also had negative amyloid and negative tau PET scans. Then there was a group that was amyloid PET positive only and tau PET negative. And then we had a group that was amyloid positive and also tau PET positive, but only in the medial temporal lobe. And this medial temporal lobe region is the region we think becomes abnormal the earliest in Alzheimer's disease, at least as detectable by PET imaging. And we also had a group with slightly more advanced tau PET positivity, now also in the lateral temporal cortex. And we hypothesized that these 2 groups, those who are both amyloid and tau PET positive, would be the fast progressors. So we tested this with progression to mild cognitive impairment as the outcome measure. So on the y-axis, you can see the survival probability of the different groups, and on the x-axis, again, the follow-up duration of the study, up to 6 years. What we can see here is, as expected, that the group that was amyloid negative and also tau PET negative They remained rather stable, so only a few individuals progressed to MCI during the course of the study. Then the group with amyloid positivity only and tau PET negative, we can see, very similar to the previous study, we can see a subtle increase in the number of individuals that progress to mild cognitive impairment, but these differences occur only relatively later on, and the differences remain rather subtle. And then if we look at the two groups that were amyloid beta positive and tau PET positive, we can see that these rates of progression are really, really much faster compared to both of the other groups. Here we translated that into the relative risk, and if we compare the groups that were both positive on amyloid and tau PET positive and compare them against the group that was only amyloid positive, you can see that there's a 6 to 8 times higher relative risk for developing MCI. So really a significant higher risk. So this is another study led by Sylvia Villeneuve at McGill in Canada. And what she did, in addition to our study, is also add a measure of neurodegeneration, in this case operationalized using cortical thickness in a very specific region for Alzheimer's disease. So she did it across multiple studies. And what you can see is if you move from the right to the left, the biomarker profile becomes more AD-like. So here we see the group that is positive on both amyloid and tau and neurodegeneration. And if we focus on these groups, we can see that between 43% and even 100% of those individuals who were initially cognitively unimpaired progressed to mild cognitive impairment. So this is just another evidence that we are able, using PET and potentially MRI, to detect clinical progression in the relative near future. Then the second thing I think we can do better as a field is when we select our region of interest for tau PET. So this is an overview of regions of interest we have used in the current literature, and we can see that there is really a wide availability of different regions of interest that are being used, and they really work well for particular purposes. But what's also important to notice is that all of these are one-size-fits-all approaches. So in other words, you take one region of interest and you apply that region to all your participants in your study or in your clinical trial. But what we know already from other studies, for example, this study by Jake Vogel, is that there is huge variability in tau PET patterns, even within the typical Alzheimer's disease spectrum. So here Jake, for example, identified 4 different subtypes of tau pathology. And we know, for example, that the epicenter, so this is the region of the brain that shows the highest tau PET load at baseline, can really differ between individuals, as you can see here. So I think this really calls towards an individualized region of interest approach. So this was studied by Antoine Leucy quite recently, and what Antoine did here is he compared these group level, one-size-fits-all approaches in blue against individualized approaches here in yellow. And the outcome measure here is the annual change in tau PET. And what you can clearly see here, if you compare the progression rates in the group level region of interest, you can see that there is a maximum 5% annual change observable. But if we go to these individualized approaches, and even including this relatively simple and straightforward epicenter approach, you can see that this number goes up to about 7.5%, and the error margin are quite comparable with the group level approaches. So in other words, I think this can really help improve the statistical power of clinical trials in the future. And the final thing I think that's really important for the field is to work on harmonization of tau PET data. I think we've been really inspired by how this has worked for the amyloid PET field, where centiloids were developed. And what centiloid essentially does is they create a single scale for different amyloid PET tracers. So a single value means the same across the different amyloid PET tracers. And this makes it possible, for example, to compare the outcomes and the efficacy of different clinical trials that have used different amyloid PET tracers to detect the potential removal of these amyloid plaques in the brain. So for tau PET, a similar initiative is going on, and the centiloid equivalent for tau PET is called centaurs. And in this initial approach, we can see that it's already possible to calibrate 2 different tau PET tracers, in this case R0948 and flutalzapir, with relatively high accuracy. So this is still work in progress. A lot needs to be done. It's also more complicated to do this for amyloid PET than for tau PET. But this is a very important development and will really help the field move forward. So to summarize this part, so tau PET is already widely implemented in clinical trials. Tau PET is a very powerful tool to enrich clinical trials for fast progressors. Individualized tau PET regions of interest could more precisely track treatment-induced changes in tau pathology, and a harmonized tau PET metric would greatly facilitate the comparison of clinical trials that employ different tau PET tracers. And the final part of this talk is the comparison between tau PET versus the elephant in the room, which is obviously the plasma biomarkers. And I think this is a really important question because the recent advent of blood-based biomarkers have really revolutionized the field, right? Because these markers are scalable, they're cost-friendly, they can reach populations that are very difficult to reach with the PET infrastructure required. So we really need to assess very carefully if there is a scenario where tau PET would still be preferred over these widely accessible plasma biomarkers. And I think there are a couple of use cases still for tau PET that I would like to mention. So this is an example where plasma p-tau, in this case 217, was used as a secondary outcome measure in a clinical trial. This was the phase 2 trial with donanemab. And what we can really nicely see here is a 23% decrease of plasma p-tau levels in the group that was treated with donanemab. So a very interesting and good result. What we also know in the study done by Nicholas Matson-Carlgren is that this is a study using the exact same assay of plasma p-tau 217 and correlating it with the pathological burden at autopsy. So we're comparing antemortem plasma analysis against postmortem tangle and plaque pathology. And what you can see is that this signal we derive from plasma p-tau 217 more or less comes equally from amyloid beta plaques and tangles. So it's not a very specific measure of tau pathology. So if you want to interpret this result, is this drop in this clinical trial of plasma p-tau 217 level, is it really a reduction of tau pathology? Is it maybe reflecting a reduction in amyloid pathology, or is it a mix of both? So I think if you really want to understand it, we still need tau PET. And it's important to notice that there's ongoing work where more tau-specific plasma biomarkers are being developed. But for now, I think in this scenario, if you really want to ensure that tau aggregates have been removed, then tau PET would still be the method of choice. Another very important question, of course, is the ability of a biomarker to predict future cognitive change. This is a study we did in a symptomatic population with mild cognitive impairment or mild dementia, and where we directly compared tau PET versus plasma p-tau 217 in conjunction with a lot of other potential biomarkers. So Ruben Smith, who led the study, performed a hierarchical model where in each subsequent model, one of the biomarkers was dropped. And the outcome measure here was a future change in the MMSE, a very global measure of cognitive change. And what we can see here is that plasma p-tau 217 was dropped in a relatively early stage already, whereas tau PET remained in all of the models and was always the most strong predictor of cognitive change over time. So in this population, tau PET is a better predictor of cognitive decline. We're also doing a very similar approach, but now in people that are cognitively unimpaired. So this is, again, it's a multi-center study in the end, but this is just by the results we found in Biofinder 2. And here we can see that the effect sizes are very comparable between plasma p-tau 217. So in other words, both of them are predicting future cognitive change, but the difference between tau PET and plasma p-tau are rather subtle. It's only a marginal better performance of tau PET. So we're currently repeating these analyses in multiple independent cohorts. And I guess in this case, if the performance is only marginally better, you would need very good reasons to actually go for tau PET scan in this particular application. So the take-home message of this talk is that I think that tau PET is an excellent diagnostic marker for selective use in the memory clinic or in the clinic in general. And tau PET is a very powerful tool to optimize clinical trials. And also, despite the advent of blood-based biomarkers, I think tau PET is really here to stay. And there's still a lot of very useful applications of tau PET. So with this, I would like to end. Thanks for your attention. And I look forward to take some questions from you, Stefan.
Thank you so much, Dr. Ossenkoppele. A very interesting talk. Yeah, so you mentioned the elephant in the room. Blood tests p-tau detect so in comparison to tau PET. I mean, what is your opinion? You alluded to it already a little bit, but could be probably as well time. Do you think this eventually could change, that blood could replace a tau PET image?
Yeah, absolutely. So I think if you nowadays give a talk about tau PET, I think you have to include the data on plasma biomarkers, right? Because the development has first of all gone very quickly, and the results are really impressive. So I think there are already scenarios where plasma would be preferable over tau PET, and especially when large volumes are required, right? So it's much easier to reach higher numbers and again reach more people when you only require a simple blood test. And the performance for particular use cases is already so good that I also think it's justified. For example, for differential diagnosis in particular populations, I think a blood test can already be very helpful.
Of course.
And I think in general, it's really a trade-off between feasibility and accuracy. I think at the moment we can really safely say that tau PET is a more accurate measure of tau aggregates, at least in Alzheimer's disease. So if you really want to measure that, then you would still resort to tau PET. But if there is less need to be super precise, I think the plasma biomarkers can already be preferred. And I think in a scenario that we're currently investigating very actively is an approach where we can actually combine them, where we maybe use plasma biomarkers for initial screening. Thereby we can reduce the number of people that actually require a PET scan by dramatic numbers. We have already shown for particular applications that the number of required tau PET scans can be reduced by 80 to 90%.
Okay.
And of course, this will really help healthcare, clinical trial designs. So either in isolation or in combination with PET, I think that there's a really big future for blood-based biomarkers. That's
well, interesting.
That's safe to say.
Yeah. Okay. Excellent. Well, looking forward to watch that and to see how it's progressing. Now, in regards to tau PET, where do you see the main challenges which might prevent the broader adoption in clinical routine?
Yeah, also a great question. So what we have already learned from the PET literature is, that tau PET scan in general is performed in rather specialized settings already. Very often in academic hospitals, where only a subset of the patients, the individuals with dementia are presenting themselves with symptoms. So that is a problem because also we have to interpret the results with a certain caution. They may not apply to other populations. So we're creating a bias based on the accessibility of this particular biomarker. I think it's a problem. And also think, with the increasing rise in the prevalence of Alzheimer's disease and other types of dementia, I simply think that the infrastructure for PET is not sufficient to reach these high numbers. In very special cases, if you require a high level of certainty, it should be an option. It has to be an option, but we really need alternatives. So for me, mainly the accessibility and the inequality that comes with a technique that requires a very heavy infrastructure are the main challenges.
Okay, interesting. So obviously today we know about amyloid and tau tracers. Mainly, do you see other tracers that could help early diagnose Alzheimer's disease?
Yeah, definitely. So I've shortly already mentioned in this talk FCG PET,
Right.
which may not be optimal for very early detection of Alzheimer's disease, but it has already been shown to be able to pick up abnormalities at the MCI stage. And FCG PET is typically more widely available, also in more peripheral hospitals. So that's of course one that's already available, and in some countries is highly used. But looking a little bit forward, I think it would be very interesting and important to have good PET tracers that measure other neuropathologies. And probably the main one of interest is a PET tracer for alpha-synuclein pathologies, both to be able to, for example, detect Parkinson's disease or Lewy body dementia, but also measure it as a comorbid pathology that comes with Alzheimer's disease. Especially at older age, Alzheimer's disease in isolation is the exception rather than the rule. So to get a complete picture of what's causing the clinical syndrome, getting a fuller picture of
Mm-hmm.
neuropathological changes is very important. And in that same realm, I also think that a tracer for TDP would be very important.
Mm-hmm.
So these are I think mainly for diagnostic purposes. To really understand the disease better, I think it will be important to better capture neuroinflammation, which we know is a key event in Alzheimer's disease. Probably in addition to A-beta and tau, the third pillar of the disease.
Mm-hmm.
Yeah, so getting a good understanding of microglial activation, of astrocytic reactivity will be key to better understand what's actually happening in individuals with Alzheimer's disease.
I see. Okay, well, thank you very much for this answer. I think we come to an end. I would like to thank you very much for your very interesting insights, excellent presentation. I especially like the summaries that you had in between the various topics. I think helped a lot to come along here. I would like to thank you for your attendance today. Please stay tuned. We will have other webinars to come, and we look forward to have you at one of the other episodes of Brain Pet Talks. Thank you so much.